Hi, I'm Dr. Marichelle Sanchez, and I'd like to welcome you to the Developmental and Behavioral Pediatrics section. I know this orientation might be the only contact you'll have with our section, but I'm sure you will still learn a lot from this presentation. One of the strengths of your rotation in the Department of Pediatrics is your exposure to the field of developmental and behavioral pediatrics. It will prepare you in understanding and managing different developmental conditions that you might encounter in whatever field you plan to pursue in the future. Since there is already an increasing prevalence of neurodevelopmental disorders not only in our country but in the whole world. Our objectives for this presentation are the following. At the end of this two-part session, you should be able to recognize children with behavioral and developmental problems, and you should be able to refer these children with confidence to your residents, fellows, and consultants. Please familiarize yourself with our section's active consultants. They are Dr. Lazaro, Dr. Pacifico, and Dr. Aguila. There are also 5 fellows in our section at present. Dr. Reyes is our senior fellow. Dr. Sanchez and Dr. Santos are currently our second-year fellows, while Dr. Piel Pacifico and Dr. De Leon are our first-year fellows. We have one recent graduate, Dr. Christine Yatko. I mentioned her because I'm sure you will still see her name in most of our follow-up patients' OPD charts. Now that you know who to refer to, we would like to give you some reminders when conducting your history taking and interview. Always remember, most of our patients and their parents are sensitive about their condition. Please display proper decorum at all times. Next, know the status of your patient. Is he our section's new patient, old patient for follow-up, or a transferee, like someone who has been seen by a developmental pediatrician from another institution and is now seeking continuity of care here in our OPD? By knowing these details, you will also know your next steps in conducting your interview and planning the developmental tools you'll need to be able to properly refer your patient. I would like to guide you with the common terms you will encounter in our section. A developmental consult is a new patient of our section, meaning they have never been seen before by any of us or any developmental pediatrician from any institution. If during your history taking and physical and neurologic examination, you noted that your patient has delays in development or has a glaring behavioral problem, bear in mind that this patient needs to undergo a formal developmental screening, which you may already ask the parent or guardian to accomplish prior to your referral. Later in the presentation, you will learn more about developmental screening. When you have established that your patient is a new referral to our section, next step is to determine the chief complaint. This slide is an example of the most common chief complaints we encountered in the OPD as reported in our annual census for 2018. Remember, as Bates' Guide to Physical Examination and History Taking defined the chief complaint, it is the one or more symptoms or concerns causing the patient to seek consult. In other words, it is also the presenting problem. I hope that we don't hear a chief complaint of for neurodevelopmental assessment again during endorsement. That's the common mistake that we hear from clerks referring to us. They only read what the triage wrote in the chief complaint and did not bother to ask the companion anymore. Please take time to ask your patient or caregivers for the primary reason why they want to seek consult with us. Another set of patients that you will see in the OPD are those who have undergone developmental consult and failed their developmental screening test. Hence, they were scheduled for a formal developmental assessment. Please review your charts since you will find all the needed information there. Usually, we schedule patients for developmental assessment on Mondays and Fridays, and our resident rotator and the cage have a copy of this list. Again, please take note of the common chief complaints during developmental assessment. Almost all the time, they are the same as the chief complaint when we see them initially during developmental consult, except for some cases when mother has new or additional concerns. Notice that there are already patients for re-evaluation in this list because we schedule them also and they come back for continuity of care. Which brings us to the next slide. Our patients for re-evaluation are those who have already been seen before. We usually attach a computerized report in the chart after evaluation, and we also give a copy to the parent or guardian. Please also know the complete history of your patient, even if the other components of the history has been accomplished by the previous clerk who saw the patient. Review them and go over them again with your patient's parents or guardians. Why? Because the information written there might not be accurate. By going over them again, you do not only retain information, you also verify them. If your patient has already been seen by our section before, please review the recommendations and plans that were indicated in the previous consult and include in your history. For laboratory or diagnostic procedures requested, please ask them to show you a copy of the results and compile them already prior to your endorsement. This will facilitate a faster turnover of patients for everybody. If your patient is already an adolescent, please use the adolescent forms available in the OPD, which include a comprehensive psychosocial history. Read your PD manual in pediatrics thoroughly. Everything you need to know is there. Some reminders when doing your physical examination. Please complete the anthropometric measurements and make sure to plot them in the correct WHO growth chart, since we need to document any presence of dysmorphism in our patients. Please get the head circumference of all the patients you will refer to us, regardless of the age. Here's a review on the proper way of measuring head circumference. You need to use a measuring tape that cannot be stretched, and you need to securely wrap it around the widest possible circumference of the head, which is at 1 to 2 finger widths above the eyebrow on the forehead and at the most prominent part of the back of the head. You have to take the measurement 3 times and select the largest measurement to the nearest 0.1 centimeter. This illustration will help you visualize the proper way to do it on babies with different head sizes. There are times that the clerks who endorse to us tell us that their PE is unremarkable. But when we examine the patients, they have cleft lip or cleft palate, or sometimes they have extra appendages. There was also a time when we heard a loud murmur when we did our cardiac examination. Please be thorough in reporting and documenting your physical examination findings, because once you do this early on, you will bring this good habit in your future practice. Please do a complete neurologic examination prior to referring to our service. Remember that a significant number of our patients also have neurologic condition. Review your PD manual, Chapter 6, to know all the components of a complete neurologic exam, especially in the pediatric age group. The most important learning outcome of your rotation in our section is for you to be able to recognize children with delays in development and atypical behaviors. For you to be able to do this confidently, you have to constantly review the developmental milestones. Please go over the next 3 slides to refresh your memory. This table is lifted from American Academy of Pediatrics, Developmental and Behavioral Pediatrics 2nd edition, published in 2018. On each well-child visit, you should always discuss about the developmental milestones of the child with the parents, for the purposes of surveillance of a child's developmental progress and for developmental promotion for the child. You will see in the tables marks of when to conduct a standardized developmental screening test, which will be discussed on the next slide. But it is important to mention that any time you or the parent flag a delay in a child's development during developmental surveillance, you may perform a formal developmental screening test at once. To give you an overview, developmental screening is the administration of a brief and standardized test about development or behavior in a clinic. Ideally, it is done at 9, 18, and 30 months of age, during the first 3 years of life. The ages for screening were selected based on times when key developmental problems can be identified. Unfortunately, this does not often happen in the OPD setting because usually caregivers bring their children when there is a long-standing problem already. In performing developmental screening, you must choose a screening test based on the factors stated in this slide. An acceptable screening test should have more than 70% sensitivity or specificity with a collective sum of at least 150%. The following are the common current developmental screening tests used in clinics. In the OPD, we recommend that you use the Filipino version of the Parents' Evaluation of Developmental Status known as PEDS for children aged 0 to 8 years old. This is what PEDS response form looks like. It is composed of 10 questions answerable by wala, meron, or konti, with space provided for comments. Please encourage parents to write an explanation, especially when they answer meron or konti. If parents only encircle answers and do not write anything on the form, you cannot be sure of literacy. You should then re-administer PEDS as an interview. Ask your developmental and behavioral pediatrics resident rotator or fellows for help on interpreting the parents' responses. Many screening tests are now available for use. When choosing, the clinician should consider the population being screened, like parental education level or languages spoken, and the test style and properties. You may ask your fellows for guidance if you wish to administer other screening tests that you think will be needed to appropriately identify your patient's concerns. Lastly, you will be asked to observe during developmental evaluations. Please make the most out of the experience by paying attention, participating in some exercises, and asking questions. I'm sure the residents, fellows, and consultants will appreciate your interest on the subject. To come up with a diagnosis, there are a lot of factors that we need to consider. There are two types of diagnosis in the field of developmental behavioral pediatrics. These are etiologic and descriptive. The distinction between the two is illustrated in this slide. Etiological diagnosis for all the neurodevelopmental neurobehavioral disorders result from an interaction between neurobiological factors and environmental experiences. This interaction can result in what has been described as developmental brain dysfunction, which produces a pattern of neurocognitive, neurobehavioral, and/or neuromotor impairments represented by Kaputa's triangle. Once this pattern of impairments has been established, descriptive developmental behavioral diagnosis can be made along the spectrum and continuum of developmental behavioral disorders. As much as possible, we want to know the underlying cause because it may lead to detection of associated anomalies or medical problems and prevent medical complication. It also allows for genetic counseling, and it provides parents peace of mind in knowing specifically why their child has a developmental behavioral disorder. You will see the importance of getting a thorough history as it helps establish an etiologic diagnosis. Another step to diagnosing a developmental and behavioral condition include a good grasp of the three fundamental neurodevelopmental processes. These are delay, dissociation, and deviation. Developmental delay refers to a significant lag in the attainment of developmental milestones. It is most commonly represented by a more global delay across all streams, which are cognitive, neurobehavioral, and motor of development. While developmental dissociation describes significant scatter of unevenness across different streams of development. Last is developmental deviation, which describes significant scatter or unevenness of abilities within a single developmental stream. It represents non-sequential unevenness in the achievement of developmental milestones. One measure that you will frequently encounter during your rotation is the developmental quotient, or DQ. It is a measure of the rate of development within a stream, and it is the metric by which delay is determined. It represents the percentage of normal development within a given stream that is present at the time of testing. In mathematical terms, it is equal to the functional age equivalent divided by the chronological age times 100. The principles of delay, dissociation, and deviation are ultimately applied in the interpretation of the developmental history of the 5 streams of development in combination with direct observations from the developmental evaluation or assessment. Gross motor delay with a developmental quotient of 50 or less is consistent with a diagnosis of cerebral palsy, regardless of the development quotients in other streams. Delay or a DQ of less than 70 in both streams of language and visual motor or nonverbal skills is diagnostic of intellectual disability and is generally accompanied by delays in adaptive skills and perhaps social skills as well. Delay in the language stream in the presence of normal visual motor skills exemplifies dissociation between the cognitive streams of development and indicates a communication disorder. Communication disorders may be accompanied by deficits in social skills as well and should signal the need for a historical review of autism symptoms and behavioral rating scales for autism symptoms. Bear in mind that this table is only a guide and is not the only reference used in coming up with the diagnosis. I just want you to see our thought process when we are interpreting the results of our developmental assessment. Remember that a thorough understanding of the key neurodevelopmental principles underlying the spectrum and continuum of developmental behavioral disorders will enhance your clinical judgment and improve your confidence and diagnostic acumen in identifying children with developmental and behavioral disorders at the earliest possible age. Thank you, and I hope you retained substantial information. See you in the clinic!